بسم الله الرحمن الرحيم. Assalamu alaikum wa rahmatullahi wa barakatuh. Um, Dear friends and colleagues, hello everybody. This is Dr. Yassin talking to you live from Seattle, Washington. Today I'm joining the Dentistry Online uh, conference, and I'm going to be talking about one topic. It's mainly bone grafting with augmentation topic, and we're gonna touch base with some of the new trend in prefabricated bone building blocks. Uh, this presentation actually is designed for intermediate to advanced level in implant dentistry. So I'm gonna touch base a little bit with basics of the bone grafting and ridge augmentation, and we'll move forward to have more advanced cases with block grafts and prefabricated block grafts. My name is Alaa Yassin. I'm Alan Yassin. I am a periodontist, dual trained periodontist and oral surgeon. I practice here in Seattle, Washington, and I am an affiliate instructor at the University of Washington. And please feel free to reach me out. This is my email address. In general, talking about implant dentistry, we all the time face several complicated cases. Some of them will be like some pathology, some bone deficiency, soft tissue deficiency, a lot of time full arches, some huge severe bone loss, which will require us a little bit more advanced techniques to rebuild our bone and soft tissue at the same time. In this presentation, we're going to discuss gradually from why to do the bone grafting. We'll discuss classification of ridge defects, diagnosis of bone loss through some radiographs and some restorative treatment planning, principles of bone augmentation, biology of bone building, bone graft materials, the membrane materials, and we're gonna run a discussion about the block graft. Is it really still the gold standard for our bone building and ridge augmentation? Autogenous bone blocks and the prefabricated allo blocks, and then we'll do the comparison to have some summary for after this presentation. So why do we do bone grafts? It's evidence right now that we have our bone loss happening after we lose our teeth after the extraction. 40 to 60% of the width of the ridge will be lost within the first year after the extraction. And you know, the pattern of bone resorption is different from the anterior maxilla to posterior mandible, but it's evidence that we lose more bone through the time. Implant needs to be surrounded like 360 degrees with bone at least to have the successful ideal implant positioning. And we remember all the time the basic concept about the bone to implant contact for the successful ideal osseointegration and the good implant, restorative over the implants. So Brenmark was, pioneer with this, even with mentioning two main factors for our successful implant or ideal implant placement: the bone to implant contact and the initial stability for the implant inside the bone host. So why should we graft? The main thing is to position our implant in the ideal position to replace the missing tooth with the ideal restoration over the placed implant. And we have some dimensions to go over: mesiodistal position, which will require us to spend some time to get at least 1.5 millimeter between a natural tooth and the adjacent implant that we're planning to place. 3 millimeter between each implant's titaniums to give some space for the bone to get some blood supply and preserve as much papilla and soft and hard tissue around the between the implants. The second dimension is the apical coronal position, which will require us to put the implant at the right place to allow us to have like the good emergence profile for the final restoration. And we know that this dimension should be uh, around 3 millimeter apical to the adjacent CEJ for the adjacent tooth. If we don't have adjacent tooth, probably we'll go with the implant for 3 to 4 millimeter uh, apical to the pregingival margins here. So this will allow us mainly to provide better emergence profile for our restoration. So try to imagine on the right side here, if we have implant very deep inside the bone, we kind of will end up with long final restoration, which will require us a little bit more maintenance and compromised implant to crown ratio, which is mechanically not right. If we have the implant shallower than it's supposed to be, the implant should be will provide us with a short crown that probably is going to be non-aesthetic, especially in the right one. So apical coronal position is very important to be placed the correct way, so we can provide the final restoration in a better emergence profile and positioning. And of course, the buccal lingual, buccal palatal positioning, that we need to put the implant on the right arch of the adjacent teeth. We are aiming all the time to do the implant in the screw retained shape to avoid the hassle of the cement retained implants. And we need at least 2 millimeter somewhere between the buccal plate and the implant itself. And finally, the angulation of the implant, especially if we are dealing with some resorption in the anterior maxilla, we need to rebuild our bone in the shape that will allow us to place the implant in the ideal position to have the ideal restoration. So, and we all know through this years in implant dentistry, it's very important to follow some guidelines and diameter of the implant. We can't really go above 3.5 millimeter in the mandibular anteriors. Personally, I do 3.0. The maxillary laterals, we go through 3.5 or less. 3.0 is fine. Maxillary centrals, somewhere between 3.5 to 4 millimeter. Maxillary canines, 3.5 to 4.5. All premolars, somewhere between 3.5 to 4.5. And the molars, it's a little bit different between the molar position and the available bone. So we need to follow the guidelines for the two-piece implants that we are using nowadays to replace the missing teeth. And we all know that the classification for our deficiencies in the ridge, it's really hammered, and we have a lot of studies showing different classification for the bone deficiency. We can call it the class 1 if we have any horizontal bone loss around the ridge augmentation, the ridge, the alveolar ridge. The class 2 is we have vertical bone loss in the alveolar ridge, and the class 3 is the classification if we have combined height and vertical dimension loss. We understand this to mainly design our treatment plan with different other classification to attach the implant placement with the bone deficiency that we have in the alveolar ridge. So either we're going to be doing class 0, 1, as we have a sufficient bone in the alveolar ridge that will allow us to place our implant inside the bone with the position that most ideally or close to the ideal position for the ideal restoration. So Schwartz in 2004 had this classification to allow us to decide, are we going to be able to place the implant without a bone graft as a class 0, or we are planning our implant to with simultaneous bone graft class 1, 2, or 3, or with the severe cases of big deficiency, big bone loss, class 4 and 5. We need to stage our implant placement into bone building, ridge augmentation, wait for the biology to heal, bone reconstruction, and then after that we'll come back and do our implant placement in the most ideal position, depending on the position of the final restoration that we are planning to do. All this will require us to do some significant diagnosis process before we decide which route should we go. And of course, we need to go through clinical examination, patient history, radiographic examination. Absolutely, in 2019, I think the three-dimensional CT scan is important in implant dentistry to decide exactly where should we place our implant and what bone graft needed, bone reconstruction. And absolutely, the golden concept of implant dentistry is start the implant dentistry from the restorative plan backwards. So it's very important for us to do either the regular wax up, setup, and move forward. So I'm going to touch base a little bit for the beginners in implant dentistry. We have this panoramic view that will give us two dimensions only in our implant study that can probably decide if we have any engagement with vital structures, the IAN and the mandible, or the sinus and the maxilla. We can study the mesiodistal position. We can study the apical coronal position of the implant. But those kind of, panoramic X-ray or the PA, the radiographs, they will not allow us to study the buccal lingual dimension, which will require a little bit more advanced techniques like the three-dimensional CBCT. One of the most important point is to know where are we going before even placing our implants. So prosthetic treatment planning is the most important part in implant dentistry, just to make sure that we know how will the crown look like after the implant placement. Are we planning some one piece, two pieces, through a bridge, fixed, removable prosthesis? So a little bit of wax up, set up to see exactly what is the final result for our implant is important to know if we need if we can do implants simultaneously with soft and hard tissue augmentation, or should we go with soft and hard tissue augmentation and stage our implant placement down the line. And of course, the CT scan is the cone beam. The CBCT is the will provide us with a lot of important information. As you know, the CT scan will provide us with three cuts. This is the axial cut, as if we're looking into the to the maxillary here, and from the bottom. If we are looking into the coronal view, exactly the panoramic X-ray, as if you're looking from the front. When looking into the sagittal cut, as if we're looking from the side. And probably the sagittal cut is pretty important, the most important cut for us to evaluate both buccal lingual and coronal apical position around the missing tooth area. And nowadays we have digital dentistry will allow us to do this setup, wax up, the restorative plan virtually on our softwares, working on the CBCT, the three-dimensional CT scan, which will give us the opportunity to put the final prosthesis in the ideal position. And we follow this with the good treatment planning for the implant positioning inside the available bone in the CT scan. Like for example, this patient is missing teeth number 2, 3, 5, and 19 and 30 in general. And with the CT scan, we can mainly evaluate the available bone and decide if we're going to do with implant with no bone graft, implant with simultaneous bone graft, or we're going to do bone graft and delayed implant placement down the line. So all the studies will give us, the digital dentistry study will give us the opportunity of treating the, changing the, whatever we have from the CBCT, and the either scanning the model or intraoral scanner to superimpose the data that we have from the radiographs with whatever clinical we have in the model or the intraoral scanner. So we can superimpose both things together, and we can design our final restoration in a way that is going to be as ideal as possible for our treatment planning. And then from there we know exactly where our crowns located, and we will be able to place our implant following the good position of the crown. And then from there we decide, for example, for tooth number 2, after putting the implant in a good positioning, that probably we need some vertical augmentation in the area. Probably we need some 2-3 millimeter of bone augmentation on the floor of the sinus. Sometimes, as we discussed, we need around 2 millimeter around of bone at the buccal side of the implant. So we know, like this implant number 5, we need to have some more bone augmentation at the buccal side. So will give us better information for our treatment planning, and we can virtually design the final prosthesis and the implant placement, which could allow us to have some guided surgery in general, fabricating the surgical guide if needed in general, to follow the ideal treatment that we already planned on the software that we are using, fabricating the surgical guide to lead us to the best drilling and implant placement inside the bone, which will follow the final and ideal positioning of the crown that we already designed on the software. So, so generally speaking, with all this details, we need to understand that we are talking about the bone grafting and bone augmentation because we are in need to place our implant in the ideal position. We don't really need to follow whatever bone available in the jaw and the mandible or the maxilla. So this is why we are talking about bone grafting or bone augmentation. And talking about this bone augmentation principles, we learned the hard way all through the years, actually, to how to augment the bone through the meaning of bone graft materials. And we're going to discuss some details about what do we have available as bone materials and membranes. And I concluded actually 9 essential principles to build our bone graft. And for me, I had this example to teach either my colleagues, my friends, and my students. And I always put the example of the tent. We all know when we go camping, for example, we need to go for 2 weeks camping. We put the tent, and we need several examples or several concepts to put our tent in a safe and predictable way. And all whatever we're gonna apply to our camping tent apply to our bone graft steps to build in our bone augmentation process. So generally speaking, we need this tent to be mobile, and this is applied to our bone graft material, where you need it stable with no mobility. We need some space maintaining to live inside the tent, so the tent does not really collapse on us, which mean that it is the same as the bone graft. We need some space maintaining, will give us some space to rebuild, to give the biology a opportunity to build our bone. And we need some kind of material with bone formation property, so we can get more bone to rebuild this bone in our side. So all these three uh, factors, they are related actually to the bone graft material. The other three factors, mainly it's related to the barrier that we are using to prepare our bone graft. Isolation from the surrounding tissues, isolation from the surrounding environment. As the tent, we need the tent to be really strong, really durable to prevent any leaking from the outside environment into the inside of the tent. Exactly like the bone graft, we need the bone graft to be separated, any hard tissue separated than any surrounding soft tissue around it. We need a perfect seal from the outside effect. So this is why we need to have really thick and nice piece of cloth actually with the tent, to just give us the seal around us without really leaking any rain or any water, the same as the primary closure that we need to achieve above our bone graft to have this perfect seal around us. We need contained environment, so we need the bone graft and the whole site of the grafted area. We need it to be contained with no other particles coming in and out. The same as the tent, which will need it just contained, and we know exactly what is the situation around it, and the space maintaining. It is the same that they discussed around the bone graft related points. The space maintaining also with the membrane is very important, because we have some kind of membranes that will allow us to uh, space ma- keep the space maintained with some kind of uh, maintaining property for we're going to talk about the membranes down the line also. And the third section is recipients site related. So we need to make sure that we have some supply exactly in the tent. We need either to have some food, some liquids, water inside the tent, or we'll ask somebody to provide us with this nutrition to survive, mainly from the outside, exactly like the blood supply. We need the bone graft to get enough blood supply from the surrounding recipient side. We need a firm contact between the tent and the underlining base. We cannot really put the tent on like discrepancy of like ground. We need to have a ground already prepared for the tent to be stable and balanced, exactly like our bone graft. We need to spend some time preparing the recipient side to receive this bone over it. We can't really put the bone over soft tissue. We can't really put the bone graft over not really adapted with the underlining actually base. And finally, we need a clean environment, either in our tent or with the bone graft. We can't really do any bone graft with underlining infection or bacteria inside it. So it is the tent example. We need to remember this. Probably this is one of the most important slides for bone grafting. The concepts that I put it myself as thinking about the bone grafting. We need to apply this 9 essential principles with every single step when we do bone graft. Either we do ridge preservation, socket grafting, all the way to the big ridge augmentation process. We're going to talk about it again and again, just to make sure that we are reaching our goal of this presentation nicely and smoothly. In summary, we use our osseous augmentation and bone grafting in implant dentistry mainly in 3 different positions. The first one is with the ridge preservation, simultaneously with the extraction, trying to preserve as much as we can from the ridge after the extraction. We have the opportunity to use bone graft simultaneously with the implant placement to enhance the thickness of the bone that we are using around the implant, especially at the buccal side of the implant. Or if we have severe deficiency, we need to go ahead and do staged bone graft and implant, so we can go ahead and do bone augmentation, wait for the biology to give us the needed bone for implant, for ideal implant placement position, and then we'll come back and do the implant placement down the line. For our bone grafts, we know that we have a lot of bone grafts materials, and any bone graft need to have some bone formation ability, infection resistance, no rejection for the bone graft, maintaining the volume, and convenient, and of course costly, reasonable for our bone graft building or bone augmentation on the ridge. Generally speaking, we have, as we know, we have 4 different materials for bone graft, or resources for the bone graft. Either we do autogenous autograft, which will be collected from the patient's own bone. We have the allograft, which is going to be collected from humans, donors, fellows, cadavers. And the xenograft is the bone that collected from other species, animals. And the final one is the alloplastic synthetic bone, that is mainly we use the hydroxyapatite and triacalcium phosphate. Um, Every single part of this bone graft materials, it has two different shapes of the bone graft, either the particles or the blocks. So the autograft, we can collect block and we can collect particles. The allograft, we have blocks and we have particles. Xenograft, we have blocks and particles, and also with the alloplastic materials, we have both sides of blocks and particles. And to understand a little bit more about how we are building our bone through the bone grafting technique or process, we need to understand how does the bone form actually, what is the process of building the bone. We have three different processes to techniques or mechanism to build the bone in the human and also in animals the same. Osteogenesis, which is the ability for the bone graft to enhance bone creation from inside the bone. So the osteoblast of the bone graft itself will participate in bone building in the area. Osteoinduction, the bone graft material will motivate, activate the cells on the recipient side to turn into bone building and osteoblast, especially with all the growth factors that this bone will have inside it. And the osteoconduction is the way of having like a matrix of materials, biocompatible material, we put it inside or surrounding the bone, and we ask the body just to resorb this material and replace it mainly with our own bone. So we talked about the four different sites of autogenous and allograft, xenograft, and synthetic. The osteogenesis materials, the only osteogenesis material we have is our autogenous bone as a human. So we take our own bone, and it's gonna help us with creating the bone needed from inside the bone graft. The osteoinduction, only the autogenous and the allograft will have this kind of materials that will help us with osteoinduction. Osteoconduction as a matrix, as a scaffold, actually, it has this property has applies mainly to autogenous and allograft, xenograft, and the synthetic materials. So we need to understand this mechanism of bone graft building or bone bridge augmentation, just to understand how we process the bone grafting, and second, how do we choose our bone graft material or the technique that we are going to be using down the line. And of course, the bone biology, the bone formation is too complicated whenever we start our blood clot and the stability of the bone graft. We're gonna start to have a lot of active cells work, blood osteoblasts, and the activation of the osteoclast begins to resorb the bone graft itself. In the case of the particulate bone graft, we have complete revascularization in between 14 to 17 days, and the creation of the new bone formation is going to be somewhere between 4 to 8 weeks. Bone remodeling will take as long as 2 years whenever we reach the bone, the volume that we need to reach in the augmented area. So the barrier membrane, as practicing, surgeons, implantologists, general dentists, periodontists, oral surgeons, we know all the time that we have this barrier membrane to protect the bone graft around it. And in definition, we need to create a closed space between the bone and the membrane to isolate any soft tissue surrounding the area from invading the bone graft material. So we need to keep it as separated as possible, the bone graft from the soft tissue needed around it. And of course, stability is very important in the whole thing. So we need to make sure that this membrane is providing us with some protection, isolation, and stability. Any membrane we're going to be using needs to have cell occlusive effect, biocompatibility, space maintenance, tissue integration, and a clinical manageability with the membrane. So we need to try to get as more uh, effective and probably not too expensive membranes. uh, we don't really need to have another surgery to remove the membrane. So we have a lot of considerations for the membrane. I'm going to talk about it one by one right now. The membranes available in the market right now, uh, we can divide it into two different big categories: the natural derived materials, which is the collagen membranes, and mostly they are resorbable, and we have a lot of other products like the acellular dermal matrix, and we have tons of membranes, different membranes, different resource. So we some membranes will be long lasting, some other membrane will be cross linked in a different techniques, and some other membranes will be designed for to be exposed to oral cavity. So we have different design for resorbable natural derived materials. The other category is the synthetic origin materials, which can be broken into resorbable and non-resorbable membrane. And again, the membrane goal, or the main function for the membrane, is just to isolate the bone graft, the hard tissue of the bone graft, and the underlying bone from any soft tissue surrounding the bone graft. So the synthetic origin, we can break it into resorbable and non-resorbable membranes. The resorbable membranes from synthetic origin could be the vicryl mesh, the polylactic acid, which is less, usable nowadays. We're gonna see a couple of examples for this resorbable synthetic origin materials. We use the non-resorbable more than the resorbable from the synthetic origin, and mainly we use it for space maintaining effect, like the PTFE, the Teflon membranes, or the titanium mesh, to protect our bone graft around the augmenting area needed. So a lot of our work will be with our resorbable membrane, collagen membrane, which is, uh, will provide us with good isolation. It's low post-operative complications. It's a rapid healing process. We don't really worry about the membrane perforation or tearing, no tissue sloughing, no delay in the healing. Uh, we don't really have a lot of space maintaining support property in this kind of membrane, the collagen membranes, and probably we don't have a lot of stability to provide for the underlying bone graft and for the membrane itself. So it's a good resorbable. We don't really need to come back and remove this membrane. Provide us good barrier, but we have some pros and cons. We use it mostly in implant dentistry. The synthetic origin, as we said, we have the PGA, we have the vicryl mesh, we have the polylactic acid. Mostly they are the resorbable part of it. It is designed for to be resorbed. It's going to take a little bit longer than the collagen membrane to be resorbed. And one of the examples that we have is this polylactic acid, the lactosorb membranes, that it's designed from the material that we use in our neurosurgery, maxillofacial surgery all the time when we do fractures on kids. If we have some um, children mandibular or maxillary fractures, we use those materials as plates because it's going to resorb down the line. It's not going to affect the growth of the kid after the accidents. So those kind of membranes, they are designed to be reshaped in the way that we can rebuild the bone, the ridge, in the very in the favorable position, favorable shape, to put our bone graft inside it. Now the problem is this membrane will be fixed. We can fix it with some screws inside the bone, And to achieve our space maintaining, to achieve our stability of the bone graft and the membrane, we need to cover it with some collagen membrane, and a lot of time those kind of polylactic acid will be not too friendly to the surrounding tissues, which will end up with exposure to this membrane following some failure. So we're still, working around those kind of concepts, and we're still finding our ways to manipulate the 9 principles that we talked about. The synthetic origin materials for non-resorbable membranes, it will mainly will contain the PTFE membranes, EPTFE, or the Teflon shaped membrane. It is more, you know, um, the PTFE is non-resorbable, so it's designed to be removed after several months, probably if we're doing a GBR or ridge augmentation. Uh, Sometimes, if we need to enhance the space maintaining around the PTFE membrane, we just enhance it with some titanium reinforcement inside it, which will allow us to reshape the ridge in the way that's going to give us more stability. Uh, a lot of time we tack those membranes around the ridge to have the stability and space maintaining property for our bone graft needs. And of course, as we got from our fellows in the orthopedic surgery, we use this titanium plates and mesh to try to contain the bone graft with more metal titanium stability and protection. And we have a lot of different shapes for the titanium mesh, either by ready to go Osseo Builder, for example, or we have some titanium mesh that we can cut and design to rebuild our ridge, protecting our bone graft, and to be covered mainly with the final resorbable membrane, collagen membrane. All the resorbable membranes, all the non-resorbable membranes and resorbable membranes need to be uh, this make the decision which one should we use depending on the defect that we're dealing with. So, for example, if we have mild to medium defect and we are able to place our implant and we are doing some simultaneous bone grafting, probably putting some resorbable membrane with some stability around the membrane with some sutures, or um, the primary closure and the tension free flap above the membrane will help us with achieving our bone augmentation needed. Whenever we need any vertical defect to be replaced and augmented, we are talking about a little bit more challenging space maintaining property that we are asking from the membranes. Probably we're going to go towards other techniques for non-resorbable membrane, or either tenting screws or tenting post. And the most complex defect, when we have the class 3 defect, it is somewhere between horizontal and vertical bone deficiency, which will require us to think twice about which bone graft, membrane should we use in our bone augmentation. And we all know that whenever we get more complex defects, we aim to have more of the non-resorbable membranes, and apparently we're talking about the titanium mesh and the PTFE with the titanium reinforcement. And whoever works in dentistry knows exactly this kind of complications that might happen in our non-resorbable membranes. The main thing is we are we are more exposed to have some exposure in the non-resorbable membranes, which will break one of the 9 principles for bone building, which is the complete sealing and the long-term primary closure, to mainly to isolate the bone graft from the surrounding environment and the bacteria, and we will gonna be having some failures. So non-resorbable membranes, they have their own complications that we see it all the time. And again, we are mainly following 9 essential principles, simple as putting our tent in a camp for several weeks to spend good time with the family. We need for the bone graft building, we need stability, no mobility in the bone graft. We need space maintaining property, trying to keep our space maintained around the bone graft. We need some material with some bone formation property. This is the 3 parts to focus on the bone graft material. And the second part we're gonna need from the barrier around the bone graft. We need a good isolation from surrounding tissues. It's the barrier, the membrane that we talked about. We need to isolate the bone graft from the soft tissue around the bone graft. We need perfect seal from the outside effects. So we need some good primary closure with tension-free flaps to help the body get some biology, to help the biology to build our own bone that we needed. Contained environment, so we need the bone and membrane to be contained in one shape without really affecting it with any mobility or any outside effects. And again, in the membrane, we need to have the space maintaining to help us with building our bone. Finally, this final three out of this 9 essential principles, it's blood supply, firm contact to the underlying bone, and good adaptation, and the clean environment. So we need to remember this 9 essential principles exactly like the 10th examples in our head to move forward. And if you think about those 9 principles and you see all the tricks that we've been doing, uh, trying to mainly resolve 2 big problems in bone graft techniques. It's stability and space maintaining. And we tried our best. We've been trying. We need to find more solution to make bone graft more predictable. And we all know that even right now, vertical bone augmentation is still not predictable with whatever we are trying to do. So we try to have bone blocks. We try to have different shapes of bone blocks to get more stability and space maintaining. The membrane tacking and trying to do the sausage way of doing some tacking in the apical side and trying to push the bone graft material long lasting, a little bit slower resorption rate of the bone graft. Tenting screw to try to push our membrane and the side of the flap, space maintaining to have bone grafting effect. Doing our horizontal mattress sutures or preosteum sutures, trying to stabilize the membrane above the bone graft material, as we talked about the polylactic acid, trying to avoid the complications of the non-resorbable membranes to some kind of resorbable membrane, but space maintaining with a space maintaining property. And again, we have the titanium mesh, titanium reinforced membranes. All of this is mainly the way that we are dealing with our bone graft concept, trying to uh, apply stability and space maintaining mainly for our bone graft site. And if we're gonna divide our bone graft in general into blocks and particulate grafts, we kind of need to think what is the differences, what is the pros and cons, what are the positives and negatives between the blocks and the particles. I put this chart together and I tried to standardize this, so I wanted just to do the comparison between the autogenous blocks and autogenous particulate grafts, just to make sure that we are making the good comparison. And I put my 9 principles for bone graft and try to see every graft ability to apply good yes or no, or good or bad on the 9 principles of the bone grafting. So let's start with the stability. The autogenous block graft has pretty much rigid stability, especially when we use this rigid fixation and screw inside the inside the block. We recommend all the time when we deal with autogenous bone to use two screws inside the block just to make sure that we are eliminating any rotating possibility around the block. How about the particulate? It's a little bit less. We put have like a three pluses here. I put for the for particulate bone grafts because we all the time we have this problem of stabilizing the bone graft. So the bone graft can't be stabilized by itself. We need to depend on the barrier membrane surrounding this particulate to have the stabilization. Space maintaining, absolutely. In the autogenous block graft, we have a good space maintaining because the block itself will provide space maintaining into the augmented area, pushing the side and pushing the flap, soft tissue surrounding it, into some nice contained space. While the particulate grafts, it could provide us with some volume of bone, but it's not really a space maintaining. We need to depend on the barrier membrane to help us having this space maintaining. The bone building effect, probably because of the nature of the particulate bone grafts, is going to give us a little bit more bone formation, especially with this particulate concept and having the blood supply inside the bone. So it's pretty similar between the block and the particulate. I put a little bit more advantage to the particulate here. Contained with the barrier, it's easier to contain our bone graft and isolate everything with the block because it's one piece. While we know with the particulate, we care about having this particulate contained. We worry if we have this particles coming out from the membranes getting into the surrounding environment, so it's a little bit harder for us to do this contained environment in the particulate bone graft. The primary closure, when we close our flap above our bone graft, probably it is easier for us to do the primary closure above the particulate because again it's less space maintaining, so we can mainly manipulate a little bit of the bone graft particles around, but it's harder to do this um, on the autogenous bone. So for the primary closure, we say it's a little bit more positive in the particles than the autogenous bone. For the blood supply, well, I mean, when we deal with the autogenous bone, the body will suffer a little bit more to have some blood supply to penetrate inside this thick autogenous bone, while in the particles, probably it's going to be a little bit easier for us to penetrate. Firm adaptation with the base, as we discussed with the tent example, we need the base to be adapted, to be prepared to receive the bone graft, and we need the bone graft to be placed on bone. We can't really place our bone graft over any soft tissue or periosteum, and the adaptation between the bone graft and the base is easier to happen with the particles, easier than the autogenous bone block. And this is one of the points that will make the autogenous blocks a little bit more challenging, and it's very skills dependent, very technique sensitive to perform. Infection resistance, I put the same because we are expecting our surgery to be perfect, isolated, infection free, and absolutely the recipient side to be infection free already and bacteria free. So if you take a look into this chart, and you see that we have some advantages for particles bone graft, but we have the most important two things in the blocks. We have the stability and the space maintaining already, and the contained via barrier already achieved actually with autogenous monoblocks. It's it's been it took us a long time not to consider the autogenous block grafts the golden standard for our implant or for the ridge augmentation and implant dentistry. So in general, we say it's still important for us, especially that we are having this problem of space maintaining and the stability of the graft. So, talking about some practical things, we are gonna see a small case, to see the autogenous bone block. We have tooth number 7 missing with this lady. We do our diagnostic, studies, especially with the CBCT. We know for sure that we have a severe deficiency in the bone. We have at least 4 millimeter of bone to be replaced, to be augmented for our ideal positioning of the implant, which will allow us to do some screw retained restoration down the line. And we know, the block grafts, it's heavily studied actually in the literature, and we know exactly that we have different sites to collect our bone blocks, either from the chin or from the ramus or extraoral, and we know the limitations for for the bone graft horizontal augmentation or vertical augmentation. Jensen and colleagues, they published this in 2009 in IDOMI, and we know for sure that we can do the most of the augmentation for 14.3% with mainly with the autogenous bone from the chin, probably blocks. And we know for sure that if we need to do any vertical bone augmentation, the most important and the most effective way to do this is the distraction osteogenesis. So we have a lot of challenges, but we know our literature, we know our studies, we know that building 3 to 4 millimeter of a bone with a bone block, autogenous bone block from the ramus would work fine with this kind of cases. It's a standard of care to do a CT scan at the posterior mandible, at the area of the donor area and in the mandible, to see exactly the dimensions of our graft and the safety dimensions around the IAN and the nerve inside the area, so we will be super safe. And before even collecting the bone graft, we need to expose the recipient site to make sure that we are having some understanding for the defect before even we get into the site of the bone graft collection. Preparing the recipient side, as we said, because we need some good contained recipient side and also some good blood supply for our bone graft. So we do our measurements. We know for sure that we need the at least 4 millimeter of bone augmentation, which sometimes will require us around 6 millimeter of thickness of bone graft, considering the possible resorption coming down the line on the bone graft and the remodeling of the bone graft. And of course, collecting the autogenous block and the ramus is technique sensitive. We need some good armamentarium from microsaw, exposure of the bone graft with the full thickness flap, knowing exactly our anatomy, doing our cuts. We with 4 cuts, one in the distal, one in the mesial, one on the coronal side, and mainly one of the apical side of the bone graft. And we can use this tips, piezo tips, actually, to do the apical cut, which is the more challenging cut in the ramus block graft. And the final separation will be with the chisels, just to make sure that we are getting safe and nice contained bone graft. Now try to imagine we have this piece of bone which is contained of with spongy bone, which is cancellous bone, and the cortical bone surrounding it. So mainly we have 2 layers of bone graft, but we need to spend some time to adapt this bone block so it can mainly get sealed into the site of the recipient site with a good bed and good adaptation and nice touch with the bed underneath it. There's the donor site. We usually leave it as is. Sometimes we put some membranes or bone wax in the area, and the body will take care of the healing. Personally, I do this decortication, preparing the bedside just as smooth as we can. We get a little bit more blood supply. We spend some time to adapt the bone block so we can have some firm contact with the bed of the bone, and then finally we're gonna have some particles around our block. And just notice that we have at least two screws around the bone block to prevent any rotary effect, and provide rigid stability around the bone. Isolation of the bone graft is very important, even with the bone block. So we put some resorbable collagen membrane and the primary closure, which could be challenging, and the blocks is very important. It's very important to deal with the donor site to make sure that we are providing no bleeding, good control around the site. And as you can notice here, when we deal with the block, because we have a huge amount of bone augmented underneath the flap, we need to make this flap a little bit longer so we can get the primary closure. So by the means of preosteum scoring or like flap brushing techniques, just to make it a little bit longer, to achieve this tension-free closure. And then down the line, we need to do the suturing, which will allow us to do the primary closure above the graft. 6 months of the healing, we can compare actually the two different types of the starting point, and then you can see the osteogenesis property of the bone will allow us with building at least another 4 millimeter of bone. We come back to place our implant, trying our best to preserve the papilla at the adjacent teeth, papillary preservation, placing the implant in the correct positioning that will allow us to fabricate a screw retained prosthesis down the line. And the healing in 2 months after the implant surgery will be ready to go for our restoration. So the main thing is to remember that we have pros and cons between the particle bone graft and the autogenous bone. The main thing with the autogenous bone is we are providing stability and space maintaining in an easy way. We are a little bit, suffering, or it's a little bit more challenging from the firm adaptation with the base with the autogenous bone graft. So, what the concerns that we have with the bone graft will be: one, the firm adaptation and the contact with the base, because with the autogenous bone, we need to spend extra time to have this bone adapted to the recipient side, which is a key factor for bone building. We need rigid stability, and as you can see here in this case, we need at least two screws in every single block that we are using in our bone augmentation. The blood supply, it's challenging to have the blood penetrate and the vessels revascularized actually inside a block of a bone, especially if we have less autogenous cancellous bone, more cortical bone. So we have these concerns also. And absolutely one of the biggest concerns for our autogenous bone is the secondary surgical site that the patient will deal with. So generally speaking, from all these concerns, we have this, um, uh, you know, uh, some new techniques coming up, like Hori technique, and I took this case from Howie Gluckman, and he's just doing a great job with getting some autogenous blocks, cutting it into pieces. And if you can imagine those kind of techniques, we are solving the problem of the adaptation of the autogenous bone to the bed, to the recipient side, by one, putting some particulate bone, autogenous bone, underneath a shield, which will provide us with stability and space maintaining. So we are getting, all in all, we are getting everything together with a little bit more advanced and surgical and more technique sensitive skills. So answering the those big concerns, we need to think a little bit out of the box and see which route should we go if we need to provide some space maintaining, stable bone graft and good adaptation between the block and the recipient side. This is when the you know, humans came with the idea of, we always use the allografts, and the allografts mainly they have this osteoinduction property that will provide us with some bone building materials in general and a property. And we tried our blocks of allograft for several times, for several years so far, and it works. And still the challenges is to have this adaptation between the block and the recipient side. And nowadays we got this new trend. This is what we are talking about in our presentation, is the prefabricated custom allograft block. So which will allow us to study the case and do exactly design the block graft in our software using the three-dimensional CT scan, and from there we can have this monoblock stabilized into the area, adapted directly, exactly like a Lego, adapted into the site, and having as much as we can from the blocks grafts into the site here. For example, one of the cases here is this lady provided to us actually with a trauma story, and she lost actually her anterior teeth with severe bone loss in the anterior maxilla. And the CBCT, you can imagine and you can appreciate a severe bone loss in the anterior maxilla, which will lead us that we need severe or advanced bone augmentation in order for us to be able to place our implants into the ideal position of the graft. And the study will start with absolutely the restorative part. So from the three-dimensional CT scan, as you can see, we just copied this in the software, and then we start the whole thing with placing our three crowns to replace the missing teeth. And from that ideal placement of the restoration, we go ahead and place our implant depending on this ideal position of the restoration. And we can see how challenging is to build this bone, because almost three of the implants, they have less bone supporting them from the natural bone. So building this bone graft block will allow us to design it from the software and know exactly how much what's the amount of the bone building needed to build this bone, considering that we are building a little bit more, considering the 25 to 30% of bone resorption and remodeling needed for the bone block. We can compensate the whatever we need from, as you can see, the bone is already covering the implants in the way that we can provide bone block milled and ready to go for us to place it at the augmented site. So mainly this is the bone block. We are going to order this block to be milled out from a human bone, and the human donor mainly will get the bone actually as a human bone coming to us. This is the final result with the bone after designing the whole block in a good dimensions. We have allograft block that it's provided to us with all induction property to be placed into the augmented the site need to be augmented. Now we've been using, allografts and particulate sizes, and sometimes with the um, blocks. The main uh, the main advantage of this customized prefabricated allograft block is the firm contact and the adaptation between the block and the recipient side, which it's really hard to achieve in our block. The second very good advantage is we're getting a block graft with the space maintaining and the stability, good healing property without even having another secondary surgery side of the patient. So for the surgery on this patient, we need to consider doing a full thickness flap in the area, knowing that we need to have some primary stability, primary closure over the bone graft. So we need to do as much dissection as we can, and then we place our bone block after preparing the site with some uh, decortication, preparing the bed. The bone block will be placed in the area, and it's very important to use at least two screws into the block to prevent any rotation into the block graft. And absolutely, we need to finalize our treatment with releasing our flap to achieve a full thickness, uh, uh, to achieve a tension-free flap closure with a primary closure, long-lasting primary closure. So we need the bone, actually the flap, to stay closed over a period of time. And absolutely, we cover our bone block with some collagen membrane to prevent as an isolation for the bone block and the particulate bone that we used. The closure of the flap over the bone block would be with several layers of horizontal mattress, more apical to the most apical side of the graft, trying to just get all the stability and the tension free flap closure. And then another layer of horizontal mattress, a little bit more coronal to the side, just to help us getting the tension free closure. And we can finalize the whole thing with some interrupted sutures. I use the PTFE for my GBR cases, and for my horizontal mattress, I use Vicryl as a resorbable sutures. We're gonna watch a little video about this and then do our summary comparing the bone block and the autogenous bone block, the allograft bone block. So far, I've tried couple of several cases, and they're working fine. Um, we need to see more results down the line and see what's the resorption side for the implant for the bone block. So we start the whole thing with a CBCT to mainly determine what is the needed site the uh, for the bone block, what is the needed size for the block, how much thickness do we need, how much length, what is the diameter of the implant to be placed, and exactly how much bone do we need to augment. Spending some time with thinking about the soft tissue management ahead of time when we do those kind of surgeries is very important for several reasons. We need to think about the blood supply, so we don't really need to do any unnecessary cuts in such surgeries. Cuts in the soft tissue will cause us some compromising into the bone, into the blood supply. Second thing, we need to think about how are we gonna do a primary closure with tension free flap over this huge amount of bone that we're gonna be augmenting with this block. One of the most important thing to consider here is to try or make sure to have the periosteum intact with the flap. So we spend extra time doing our dissection and those kind of surgery just to make sure that we have a periosteum intact with the flap with us, simply because the periosteum could be considered as a barrier containing everything. And of course, we need to try to keep our, uh, the flap as healthy as we can. As you can see, we keep doing some hydration to the flap through our work. Those kind of cases with the trauma will end up with some fibrous tissue around, so it's not too easy to have full thickness flap with the periosteum, and the dissection of the area is pretty much hard. Uh, we need to make sure that we are not perforating into the flap and we are keeping everything intact, because remember the 9 principles for the bone building. We need isolation of the membrane of the bone grafts through a membrane and the contained environment. So spending some time doing our dissection and our reflection of the flap is priceless, especially when we do this kind of trauma patients that will end up with some fibrous tissues. Now, it's very important to design our flap in the way that it will help us with our tension-free and primary closure. And as you can see, it took me some time to think how are we gonna do our vertical cut in this area. And I decided just to go more mesial for this adjacent teeth, so I can mainly work on the flap. If I want to go dissection, as you could see, I went all the way dissected to the nasal floor, so I can get as much as I can for coronally position flap, so I can cover my bone block. Remember, we discussed that with the bone block, with this volume of the bone, it's pretty hard to have this final, a primary closure with tension-free flap. So we have our bone block ready. We prepared the site. We did some decortication. The bone block, I soaked it actually in IPRF, just trying to get a little bit more growth factors inside the bone and to support mainly the soft tissue healing around the bone. And then we put the bone and we stabilize the bone block with rigid fixation, apparently with this screws fixation. And I started with 2 screws, and I felt not too comfortable with the stability that I am getting, so I just decided to go with a 3rd screw to have the most rigid stability for the bone, because remember, we need to have stability of the bone, and we need already to have we already have space maintaining with our block, so it's pretty much getting the main 2 points with the space maintaining and stability with this bone block, with the advantage of having the bone block adapted 100% to the adjacent to the underlining area of the bone, providing pretty much great adaptation with a nice blood supply to the block. So IPRF trying exactly to get a little bit more enhancement for the soft tissue healing surrounding this bone block. After stabilizing the block, we need to make sure that we are not abusing the adjacent teeth. So for example, this kind of bone is pretty close to the adjacent tooth. We need to open a good space for the biology to heal. If we feel that the vertical augmentation on the block here, it's a little bit over augmented, we need just to decrease this augmentation. We don't really need to have any um, uh, thin or any sharp edges around the bone graft, and we need to make sure that we are uh, preparing the bone graft to be as friendly as we can for the surrounding soft tissue that will gonna provide us with a primary closure and providing us with mainly some containing for the whole bone surrounding it. And finally, you can see that I already worked with my flap to coronally position it and close all the way above the bone graft, the bone block. We need to apply some bone particles around the bone block, just to make sure that we are filling the gaps surrounding the area, and then we'll cover everything with a barrier membrane, which will allow us to isolate this uh, hard tissue uh, uh, hard tissue cells from the soft tissue surrounding it. In this case, I used double membranes, collagen membranes, just to get a little bit more support. And we end up with doing some good, uh, because we did good management for the flap, so we can get longer soft tissue flap with coronally repositioned flap to cover this bone. So now we are able to have some tension-free closure with long-lasting primary closure above our bone graft in general. Now, somebody can ask, what will happen with the vestibule here, and how about the mucogingival junction? And honestly, with those kind of bone building, huge bone augmentation, we need mainly to focus on the bone building principles and get as much bone augmentation we need. And on the second stage, when we come back to remove either the screws or to place the implant, we can go again and do the uh, apical position flap to mainly make sure that we are getting the mucogingival junction and the and the vestibule to the right positioning. So the suturing, we started, as you could see, with the horizontal mattress sutures, two layers of the horizontal mattress using the vicryl sutures here on the top, and a second layer of the horizontal mattress to close it. This healing was apparently, I think, 6 weeks after the surgery, and after that we followed up with 2 months with the surgery. You can see with the CBCT we have a good formation of the bone, we have good quality of the nice surrounding bone. This case is almost 6 months and we have no complications. As you can see, the main thing I was afraid of as a periodontist is the recession with the adjacent teeth, because we decided to go with the mesial cut here in order to be able to coronally position the flap. So we ended up with very minimum defect, and I expect things to be in a better way down the line. So as you can see, we already achieved good results. We can get nice results with not even another secondary surgery. And to do this final comparison, that just to make sure that we are comparing two blocks between each other, the autogenous bone block and the customized allograft blocks. We all know that blocks will give us a lot of advantage in our ridge augmentation techniques. The autogenous bone and the customized allograft blocks will give us some good stability, both sides. Both of them, they will give us some space maintaining ability in general, that will give us the good size of space maintaining. Osteogenesis effect, absolutely, the autogenous bone will give us a little bit more bone formation property more than the customized allograft. Contained via barrier, both of them, because they have good, nice borders around it, surround the bone block, will give us some good um, contained environment. Primary closure over the graft is a little bit more challenging in both blocks to have all this material covered with the flap. The blood supply, it's almost the same. It's a little bit more challenging with the blocks to have more blood supply and vascularization into our blocks. Absolutely, the main advantage with our customized allograft block is the firm adaptation with the base and with the nice contact with the base of the bone, because it's already designed for this defect. While we always, have concerns with the autogenous bone block to have this adaptation with the with the bed of the recipient side. And finally, with the infection resistance, I put them as similar to both with the allograft and autogenous bone. So in summary, we have a lot of techniques to build our ridges. We know for sure that blocks are really, you know, probably they are not still the gold standard right now in 2019, but blocks will give us a lot of advantages in our bone augmentation. The bone resorption probably in the allograft is a little bit more critical than the autogenous bone blocks, but we have another option right now because we are getting all these positive things that we are getting, especially this, nice designed firm adaptation with the base of the recipient side from the customized allograft. So we have this technique, we can use it, we can still use our autogenous bone blocks. We have a lot of advancement in the bone and the bone augmentation going through this as I showed this Huri technique, putting some cortical bones surrounding some particulate grafts into the autogenous bone, um, and all the way up to the customized allograft blocks. So I hope that we covered everything in this presentation, from mainly from the basics, from the literature, from the bone materials, the membrane material. This is my wife, Dr. Layla Yassin. She is a faculty at the oral surgery department at the University of Washington. We both are active here in Seattle in education, so we do our courses to teach not only dental implantology but also anything in perio and periodontics and oral surgery training. Um, both hands-on and live surgeries. Please feel free to reach out to me. This is my contact information, either by the email, by the phone, or either by the social media if you have any question. Well, thank you very much for watching. It's been my pleasure to participate in this nice conference. And I hope you get a lot of benefit from this. And again, if you have any question, please don't hesitate to contact me. Thank you very much and have a great day. Assalamu alaikum.